Hello again, it's Adam, and this is the last video for the semester, so that's pretty exciting. This is going to be our Test 4 review, and I have received 0 questions for this one, so I'll just keep on assuming my teaching prowess is such that you guys have a complete mastery of the topics. But just in case, I will go ahead and review some of the big concepts, things that I think are important for the test. So one of the big things from the tox perspective is to have a good idea of what the different toxidromes look like. So certainly what kind of signs and symptoms are consistent with those. So say for instance I had a patient who came in and they were tacking away in the 130s, having ultramental status, having hallucinations, they had mydriatic pupils, they had absent bowel sounds, they were hyperthermic. What type of toxidrome would that be consistent with? And so you'd have to kind of go through and say, like, okay, well, it sounds kind of like maybe it's a sympathomimetic, or maybe they're withdrawing from something, but maybe, the decreased bowel sounds kind of sound a lot more like an anticholinergic. That would all be something that would be kind of up for grabs as far as testing purposes go. Obviously know that things like sedative hypnotics and opioids obviously look pretty similar, but you'll see more things like respiratory depression is certainly more consistent with pure opioid ingestions, but certainly if you have multiple sedative hypnotics on board, they can look very similar. Keep in mind as well with the opiates that not all of them are going to look super classic. So you don't always assume that a patient who comes in with an opioid overdose is going to have pinpoint pupils, because you will see some exceptions to that rule. So general things like that. Just be aware of what's consistent with what those toxidromes are, and be able to kind of differentiate between one versus the other. Also have a good idea to go along with those toxidromes, what would be some of the more common antidotes. So just a few of the things that I know we talked about include things like atropine and 2-PAM, which obviously we would use for a like an acetylcholinesterase inhibitor, which would be responsible for causing a cholinergic toxidrome. Remember, those agents that are able to inhibit acetylcholinesterase lead to increased amounts of acetylcholine, leading to overactivation of the muscarinic and the nicotinic receptors. And keep in mind, there's 2 different types of symptoms you see depending on which receptor subtype is being activated more. Or there's different mnemonics between the muscarinic signs and symptoms versus the nicotinic signs and symptoms. Be aware of the difference in the mechanisms of action between atropine and 2-PAM. Now, the atropine is, an anticholinergic by blocking the receptors, versus 2-PAM actually prevents that aging process from occurring and actually helps to regenerate the acetylcholinesterase. Naloxone would obviously be for our opioids. Again, that is going to work as a opioid receptor antagonist. And then be aware that flumazenil does not work across the board for all sedative hypnotics, but will work specifically for the benzodiazepines. That's really where you're going to see the biggest use for it at, right? Because they're going to be inhibiting the activity of benzos at that benzodiazepine receptor. So they don't specifically block the actions of GABA, but they block the actions of those benzos. Other things to remember as well are going to be contraindications, and certainly some of the side effects you can see from these medications. So for instance, if you have a patient who is chronically taking things like benzodiazepines, and they are chronically kind of habituated to having that extra GABA activity around, well, if I reverse that all of a sudden, and I don't have enough GABA activity, then I run the risk of developing seizures. So withdrawal seizures can be a really big thing, and why flumazenil sometimes should be given pretty cautiously. With physostigmine, that would be the antidote for our anticholinergics. Again, this is going to be one of those reversible acetylcholinesterase inhibitors. So say I had something like Jimson weed or Angel's trumpet, or if someone had overdosed on a lot of, say, like Benadryl or any other first generation antihistamines, physostigmine is going to be a good agent to help reverse a lot of those effects. But obviously, being an acetylcholinesterase inhibitor, if I give it too quickly, what kind of adverse effects would I expect to see? Well, if I have too much blockade of acetylcholinesterase, I'm going to have too much acetylcholine, and that's going to kind of have some of the signs and symptoms of a cholinergic toxidrome, right? That's going to be our dumbbells. That's going to be like defecation, urination, meiosis, bradycardia, bronchuria, bronchospasm, urination, lacrimation, and salivation. So again, sorry if I forgot the emesis there, but regardless, be aware that what the type of side effects you can expect to see with these agents based on their mechanism of action. We talked a lot about different types of drugs of abuse, just to kind of get you aware of things that are out there, some of the trends, and so you might be aware of things you might see out in clinical practice. Be aware of what the different mechanisms are between the different agents. So obviously something like marijuana is not going to act the same as something like cocaine. They're obviously going to have different mechanisms of action, how they're going to cause their psychological effects. Be aware of things like, what's the major neurotransmitter that's responsible for a lot of the hallucinogenic effects from some of these agents. Well, that would be serotonin. So that's going to be really important for things like your LSD. It'll be important for other hallucinogens like your bufotodes that produce that bufotenin. Peyote, mescaline, things like that are going to be working more through serotonin to cause those kind of hallucinatory effects. Whereas on the other hand, a lot of things like your amphetamines and your cocaines, like they're going to be either inhibiting the breakdown of catecholamines like norepinephrine and epinephrine, or promoting the release of those catecholamines from the synapse, or even blocking the reuptake thereof. By doing all of that, they can increase the levels of those catecholamines at the synapse, and thus cause the sympathetic nervous system to kind of go in overdrive. So that's where you see a lot of the tachycardia, hypertension, sweating, all of that stuff associated with it. Other things to note as well are going to be the pharmacokinetics of those agents and how that's going to affect both the duration and the onset of action. So say, for instance, if I had someone who snorted cocaine versus smoked crack, which one would I expect to have a lot faster onset of action? Well, we said that when you are able to inhale it after smoking, that gets to the bloodstream very, very quickly. It gets up to the CNS where it has its effects. Snorting, it's still pretty fast. It's not going to be as fast as the IV or the inhaled route. So be aware of the differences there, but also be aware of the fact that, when I inhale something, it's going to be getting to the CNS much more quickly, and you'll have a lot higher peak level, and that's what causes that big surge in dopamine, which leads to the addictiveness of these agents. Obviously, oral is going to have the slowest onset, but it's probably also going to have the longest duration of action. So just be aware of some of the kind of broad strokes as far as the kinetics go with these agents. Next, we talked about envenomations. One of the things to focus on would be how to identify venomous snakes in Florida. So especially where you have, the two main classes. So we talked about the Crotallidae or the pit vipers. It's going to be our rattlesnakes or copperheads, water moccasins. And then we talked about the Elapidae or the coral snake, right? So the eastern coral snake is a big one we see here in Florida. And be aware of how to identify those, because that can be really important, especially if you have a patient who is envenomated and they do not have a picture of the snake, or if they don't actually have the body of the snake to go off of. So being aware of things like the color banding pattern on coral snakes, how you can tell the difference between a venomous coral snake versus a king snake, right? That red on yellow kill a fellow mnemonic. On the other hand, with the pit vipers, there's lots of telltale signs. So obviously the big fangs are kind of a dead giveaway. The elliptical pupils, the anal plates, the rattle, which may or may not be there depending on where the snake's at and what type of snake it is. But just be aware of the different things that might help you to identify whether or not one of these snakes are going to be poisonous or not, because that can be really important as far as whether or not you are going to be more worried about having to treat that patient with antidote or not. Be aware of some of the differences in the clinical effects in which you might see from these different envenomations. So this kind of goes not only with the snakes, but also a lot of the insects we saw and the arachnids. Obviously a black widow bite is going to look a lot different than a brown recluse bite, which is going to be a little bit different than caterpillar sting and scorpions. So be aware of kind of the big differences there, especially with things like, they're going to be causing more neurologic signs and symptoms is really important. So especially like the coral snakes, because that can be imminently most deadly if they end up having diaphragmatic paralysis because of that, right? And then based on that, based on the clinical effects you're seeing, deciding when to treat. So things like, the coral snakes, and if I start to see some of those neurologic signs and symptoms like paresthesias or ptosis or anything like that, that's going to be a clear-cut sign I need to treat that patient. Versus with something like a pit viper, if I have when I start to have increased or progression of swelling, or if I start to see coagulopathy, like those are all going to be big signs to treat. And that's important to know when to treat and when not to, because obviously these antidotes have no shortage of adverse effects, and they're also very, very expensive, especially things like Crofab. It can be upwards of $1,800 a vial. You can definitely spend a lot of money by treating these patients, and so you want to make sure you're treating them appropriately. Um, Obviously, with antidotes that are based on equine or horse protein that are the full antibody, remember that those are going to be highly immunogenic. They're very, very likely to cause anaphylaxis in your patients. And so it's important to make sure we're doing skin tests to make sure we know whether or not they're going to have a reaction up front. Or at least to give us an idea of whether or not the patient will definitely have a reaction, and then how to monitor that, and you guys know how to treat allergic reactions at this point. And then just general management of marine envenomations. I'm obviously not going to ask you to be able to identify the difference between a box jellyfish and Urological, but just be aware of kind of how do you do general first aid for someone who say you're working at the beach one day, and you have someone who comes up who still has the tentacles from the jellyfish on your leg. Well, how do you get those off? How do you keep the nematocysts from firing more so than they already have? So those are all important things to kind of remember. Remember general management for things, especially like with fish envenomations. How heat is useful for damaging and denaturing a lot of those painful proteins that are causing pain for your patient. Things like that are good to remember. Then we had our urology section. So we talked about things like erectile dysfunction. It's always important in these sections to remember things that certain medications that can actually cause the disease in and of itself. So obviously we talked about different medications, especially things like psych medications like SSRIs can lead to impotence. Certainly certain blood pressure medications may exacerbate this. So be aware of what type of medications can be responsible. Be aware of the mechanism of action of the medications that we're going to use in order to treat this. So kind of the major ways that we're going to do this to kind of increase blood flow is going to be mainly to inhibit that breakdown of phosphodiesterase, right? So phosphodiesterase inhibitors are going to be a big one that we're going to be using there by blocking that PDE5. But then also be aware of things like alprostadil and how those are going to work differently than your phosphodiesterase inhibitors. Definitely be aware of drug interactions, because that can be huge for a lot of your patients, especially if they're chronically taking nitrates for their angina. And things like that. Those are good to know. Also be aware of contraindications and just in general other adverse effects. Things like, if a patient starts to complain of change in vision, that can be a really big deal due to that phosphodiesterase inhibition for some of your patients. So again, be aware of which ones kind of have more specificity for the different subtypes of that enzyme. So that can be important whether it's PD11 or PDE6 specific, because that's going to be important for drug selection for your patients. Then we have BPH, again, another pretty similar things you'd want to know here. Again, being aware of the different medications we're going to use, their mechanisms of action, how they may work for certain symptoms versus others. So especially things like the irritative symptoms versus the more obstructive symptoms and things like that. Because obviously one medication may not be appropriate for every patient. So you need to be really careful when you're selecting which ones and make sure it's appropriate for those guys. Obviously, there's going to be lots of drug causes that go to cause BPH as well, so be aware of those in addition. And then, again, very similar looking slide with urinary continence. Again, we talked a lot about our anticholinergics. They're going to be useful for treating this. Again, very similar things you want to know. Again, trying to pick the best drug based on your patient. What type of the comorbidities they have, what other drugs are they taking, things like that can be important there. Next up, we had our immunization section. So some of the big key points, as I said, no point in memorizing the entire CDC recommendations for birth through 18 years, because again, it's going to be on the office wall. You're going to be able to consult that all the time out in clinical practice. Most providers are not going to memorize that entire list anyway. But it is important to know is some of the underlying concepts behind why we are giving these immunizations as we are. So be aware of the different ways in which the immunity is going to be occurring with these vaccines. So obviously, with live vaccines or live attenuated vaccines, you're going to be getting a little bit different type of immune response than you would if you gave only a toxoid, or only if you gave a partial, kind of polysaccharide conjugate of one of these diseases. Remember who should be vaccinated and when they should be vaccinated. So things like timing of vaccines, like, okay, well, can I give live and inactivated vaccines together? Can I give 2 live vaccines together? How about if I give them at different times? When is that going to be okay? And then also looking at your contraindications. So be aware of who can receive vaccines depending on the type of vaccine you're going to be giving. So say, for instance, you have a pregnant patient. Or say you have someone who's significantly immunocompromised, like an AIDS patient, or what type of vaccines would they be contraindicated from getting based on, and why is that? What things are you worried about by giving a certain type of vaccine to those patients? And then we also talked a little bit about specific vaccines, just to kind of get a little bit more into some of the details, especially for things that are either kind of newer or things that are kind of unique, or things you're just going to see very commonly. So like for HPV, obviously, they came out originally to help prevent spread of HPV, but also to reduce the risk of cervical cancer. But, also there's some benefit for some males to receive this, and which version of the HPV vaccine should they receive based on the subtypes, what kinds really make sense for them. Looking at things like rabies, like, okay, well, we have the rabies vaccine. We also have the immune globulin. What's unique about the immune globulin, how you have to administer that versus the vaccine, and when you give which one may be important to remember. And then obviously the flu vaccine, because it is so common, people should be receiving it every year. What are some of the differences between the flu vaccine? How often should I be giving it to patients? Do some of them get it more often than others? Are some patients not supposed to receive it at all? Things like that should be considered. And then finally, we talked about headache disorders. So obviously, lots of different causes of drugs leading to headaches. But then looking at our different medications, look at their mechanisms of action and how they're going to be working. Specifically, things like, okay, well, are they working on causing vasoconstriction by activating the serotonin receptors? Are they going to be working to help reduce nausea and vomiting because they're going to be acting at blocking dopamine receptors in other areas, or blocking working by anticholinergic mechanisms of action? So be aware of the different places where these different drugs are going to be working. Definitely be aware of drug interactions, so especially things like propranolol, like which one of the triptans will that interact with to increase your AUC. Things like which type of medications can I give in concert with one another. Can I give DHE, dihydroergotamine? Can I give it to a patient and then that doesn't work, give them a triptan next? Is that going to be okay? Then be aware of your contraindications, especially with some of these causing a lot of vasoconstriction. That can be a big problem if they have chronic angina and things like that. And then obviously, again, drug selection based on your patient. What's going to be best for them? Are they pregnant? Which medications can they receive? Which ones shouldn't they receive? Those are all going to be really important things to note. Okay, so that's going to be the end of the review. I guess I didn't get any questions from anyone previous to this recording, but please feel free up until the test. I'll try to get back to you. Obviously, the sooner you get the questions in, the more likely you are to get a response. And just like I said in class, if you guys are going out there on your rotations, if anything comes up and you guys have questions, I want to stay a resource for you guys. So feel free to shoot me an email. More than happy to see if I can help you guys out however I can. I'm sure everyone has my Gmail address. It's usually the easiest way to get a hold of me. But thank you guys for such a great year. I had an awesome time, and again, I will definitely send out baby pictures when Lily makes her grand arrival. And thanks for everything. All right, I'll see you guys around.